So we have picked different cancers for different months, and Sid is going to moderate this. Sid, can you explain more about this?
Yeah, so this is basically a molecular tumor board. We have few cases that we talk about, look at interesting molecular alterations that may be present, and then talk about how that might impact our management decisions. And so for today, we are talking about breast cancer, and we have a couple of cases, and we will be joined by Dr. Sirohi and Dr. Yan as faculty members for this discussions today. So this is supposed to be interactive, so we are hoping that people will participate, chip in their thoughts as well.
Absolutely. So we are waiting for Dr. Sirohi and Dr. Yan.
Yeah. And you can see my screen now at your end, Dr. Shah, right?
That is correct. I think all of us should be able to see that. Gautam,
The presentation. Yeah, the first slide right now, it should be showing up, correct?
Mm-hmm.
Yeah, okay, great.
Yep, I can see it.
So in the meantime, I would ask others to introduce themselves. Dr. Mittal, can you unmute yourself and introduce yourself?
Hi, I'm Dr. Abhinil. I'm a resident in Department of Medical Oncology at AIIMS, New Delhi.
Great to have you here.
Yeah, welcome.
And I see Dr. Bishnu Singh.
Hi everyone, my name is Bishnu Singh, and so are you? Okay, and I'm currently in Nepal. I'm a medical officer working in Etara City Hospital, and I am ECFMG certified physician, and I am applying for this year residency in the United States.
Welcome.
Thank you.
Great to have you here. Dr. Aditya, can you introduce yourself? Bhavna, is that you, your music in background?
Yes, I'm here. There's no music.
All right, sounds like we're trying to make it musical.
Okay, good morning.
Good morning, Dr. Sirohi.
Good morning, good morning.
Great to have you.
So we are having it's global. I think we may have some from India join as well, hopefully.
Yeah, we just heard, I think, from Avinel, who is a fellow in oncology at AIIMS. So seems like there are people from Nepal, India, and then people in the US. So it's great.
Great.
Yeah, so let me see. Aditya, can you introduce yourself? No, okay. Dr. Rupesh, can you introduce yourself?
Hello everyone, this is Dr. Rupesh from Nepal, and I'm a clinical geneticist and a fellow hematologist at Civil Service Hospital. So this is all about me. And Bhavna madam, I have seen your presentation 2 days back in an Indian conference. Hope this time I'll learn more from you.
Okay, thank you.
Great to have you, Dr. Rupesh. Dr. Osin, how about, you guys can unmute yourself and introduce yourself before we start the meeting. One by one. Dr. Prem?
I'm Dr. Prem. I'm working as a medical officer in Binaytara Cancer Center in Janakpur.
Thank you. Great to have you here. Dr. Sabu?
Good evening, sir. Good evening.
Evening. Sounds like there's a little background noise. Is it Dr. Sapku or Brahma?
Not me.
Okay. Sabu, can you mute yourself, please? Thank you. All right. So we are still waiting for Dr. Yan.
Yeah.
Sometimes there could be issues.
Yeah, just checking to see if she sent anything at all.
Yeah.
While we're waiting, good morning. This is Gassan Abafar from Sloan Kettering, New York. Looking forward to listen to Dr. Sirohi, Dr. Yan. Bhawna, it's so nice to see you. And as you know, I'm a cancer, but I learned from you.
Thank you. No, I learned from you. So thank you for agreeing to do our GI meeting on 21st, 22nd. I think everybody in India is looking forward to it. And I'll share it with you as well, Binay, for folks in Nepal as well. So we're trying to do an HPB course, just 1.5 hours in the evening. Because so much has happened in HPB this year that it's so exciting.
All by all means, happy to.
Thank you. I read your paper, Sid. Hopefully we'll discuss that, which was published last month. I think it's a great effort.
Oh, thank you.
Thank you.
On BRCA, but I think we need to maybe try and do some in the young patients we are seeing with gallbladder, because BRCA is now, in biliary tract cancers. I think we need to kind of do it routinely because normally we just don't do it.
Yeah. Yeah, and I think Dr. Abu Alpha, that's where he has been involved with BTF. We are trying to create a collaboration looking into some of the genomics in gallbladder cancer as well. And I think that's where Dr. Abu Alpha has been very helpful in trying to make that happen.
Yeah, because the patients are so young. They're in their late 20s, 30s, which is very unlike what you would see in the West.
Yeah.
So I just sent message to her, so I'm hoping she'll join us soon. But in the meantime, in the interest of time, I think Siddhartha should move ahead. Before you start, I suggest let's ask everybody to introduce themselves. Brahma, can you introduce yourself, please, to everybody?
Yes, of course. This is Brahma Kanda.
Can you mute yourself, Gopal? Gopal, can you mute yourself? Thank you. And so I would ask all of you to mute yourself if you are not speaking, irrespective of who you are and where you are from, because it is very critical for us to have a very smooth and effective webinar that is going to be a good educational experience for all of us. And today you have very high quality faculty here and outstanding people attending these meetings. Well, I'm Dr. Binay Shah, president of BTF, and I normally host this weekly tumor board. I would like to introduce Dr. Siddhartha Yadav. Many of you know him. He is an outstanding physician and oncologist, recently graduated from fellowship, and is a faculty at Mayo Clinic. His interests are women's cancer and genetics. So he will be moderating this meeting. Siddharth, would you please introduce our faculties and talk about the agenda, how we are going to move on?
Yes, definitely. So good morning, everybody, and welcome to this multidisciplinary molecular tumor board. Today we'll be talking about breast cancer cases and some molecular alterations and how that may impact clinical management. So to start with, So these are our disclosures before I go into the introduction. So for today, for faculty, we heard from Dr. Shah, who is the president of the Binaytara Foundation. So I'm Dr. Siddhartha Yadav. I'm an assistant professor of oncology at Mayo Clinic. I recently graduated from fellowship. I do breast and GYN oncology, and my interest is inherited cancers and germline genetics. For faculty member, we have Dr. Bhawna Sirohi, who is a consultant medical oncologist at Max Institute of Cancer Care. She is a well-known, a reputed oncologist, renowned person throughout the world. And she trained at in the UK and is now working in New Delhi and is involved in a lot of research and also is highly interested in ensuring that the disparities in cancer care is addressed. So welcome, Dr. Sirohi. We're really very pleased to have you today.
Thank you. Thank you, Siddharth.
And I think we're still waiting for Dr. Yan. She is a medical oncologist at Swedish Oncology in Seattle, and we will hopefully hear from her soon. We also have Dr. YP.
She has joined us. Dr. Yan is already here.
Great. Welcome, Dr. Yan. So I don't know if you want to say a few words, sir.
Sorry, can you hear me all right?
Yeah, great to have you over here.
Yeah, sorry, I was struggling with the app. Nice to see you, everyone. Thank you for having me. And sorry again, I'm running late.
Yep, not at all. We also have several other faculty members and distinguished guests from all around the world. We have Dr. YP Singh, who is a breast cancer surgeon in Nepal and is also heavily involved with the Binaytara Foundation as well. We have Dr. Abu Alfa from Memorial, who is a gallbladder and hepatobiliary expert, medical oncologist. So to start with, since we have quite some grounds to cover, I will directly delve into the cases and go into the discussions. So to start with, because we want to make this interactive, I think what would be helpful is if anybody has any questions or comments, I think it would be helpful if they could write it down in the chat section. If you have any important comments to make, then maybe raise your hand, and I hope you know how to do that. There is down at the bottom, there is an option to be able to raise your hand to say that I have an important comment to make. So we should be able to do that. All right, so let's start with our case number 1. So this is a case of a 46-year-old female, and she was diagnosed with metastatic breast cancer, multiple bone metastases, and this was back in November of 2016. The tumor was noted to be strongly estrogen and progesterone receptor positive and HER2 negative. She has undergone bilateral salpingo-oophorectomy and was initially treated with palbociclib and letrozole. She also received denosumab. So it seems like she did well for almost 3 years on this treatment before she was noted to have progressive disease with increased activity of the bone lesions. So at this time, because there was disease progression, it was decided that, well, let's look at molecular profiling, and a Guardant 360 was ordered. She also received palliative radiotherapy as part of the treatment. So if we think from a treatment standpoint, if we don't look at the Guardant 360 results, in anybody who has progressed on palbociclib and anastrozole or letrozole, the next logical step would be thinking about either exemestane and everolimus, fulvestrant, or even chemotherapy options would be reasonable. So moving on to the Guardant 360. So I don't know if everybody knows about Guardant 360 or not. For people in Nepal, so Guardant 360 is a liquid biopsy. So you are taking the blood and you're looking into the tumor DNA in the blood and trying to figure out what genomic alterations does the tumor have. So instead of doing a repeat biopsy, this is just drawing a blood and running this. So on the Guardant 360, she was found to have ESR1 PIK3CA and EGFR amplification. So the ESR1 and PIK3CA are mutations. The EGFR is an amplification. So before we go into talking about some of these genomic alterations, I think it is very important to think about, when would you order a ctDNA, like a blood liquid biopsy, versus when would you do a new biopsy and do a tumor sequencing? And just trying to highlight some of the differences between the two. So Guardant 360, like a liquid biopsy kind of platform, they usually only analyze a limited number of genes. So for instance, in Guardant, there's 74 genes that are analyzed, whereas if you do a molecular tumor and NGS sequencing, they usually analyze 300 plus, depending on the panel that you order. And then this is something interesting that I think is important to look at is what are the difference in the results that you may obtain based on Guardant versus your molecular tumor sequencing. So if you look at these are from the same patients. They looked at genes that were common for Guardant and Foundation One. What they found was very interesting is that in 20% of cases, so the green in this over here denotes the concordance, meaning they found the same genomic alterations in Guardant and Foundation One. In the red, you see, which is almost 30% of cases, they found the genomic alteration in Guardant 360, but did not find anything in the tumor genomic sequencing. In the blue, which is almost 50%, they found genomic alteration in the tumor sequencing, but did not find anything on the Guardant 360. So I think that's one of the things I think we always wonder about is should you order a liquid biopsy or should you do a repeat biopsy if you want to get some genomic sequencing? And I think I would like to bring in Dr. Sirohi over here and talk a little bit about her approach in terms of when would you order a liquid biopsy versus do a repeat tumor biopsy and order sequencing.
So ideally, I think to try and understand why a patient has progressed, ideally, I would love to do a genome sequencing on the tissue at the time of relapse. So this lady had bone-only metastasis. So we see patients like this patient quite often. We do not have an accessible site. And with bone, again, with the issues relating to decalcification and everything, we may not be able to get good DNA as well. So I think that's why we opted for ctDNA in this patient. So like I said, ideally, I would love to do it in every patient, but cost is a major issue in ordering these tests. And I would say in 80 to 90% of our patients, we end up starting treatment second line or even third line without doing any of these tests, mainly because of cost issue. So, I mean, looking at this paper, I think both are complementary. So in a patient, you would want to do a tissue sampling as well, tumor sequencing, and also liquid biopsy. And a liquid biopsy is attractive because it's non-invasive. You can look at intratumoral heterogeneity and also the heterogeneity at the time of metastasis, unlike in a tumor biopsy, because you can't go on biopsying every single site in the body. So ideally, I think I would prefer to do a liquid biopsy compared to a tissue biopsy. But again, both of them have their pros and cons as far as the strategies are concerned.
That's a very good point. Dr. Yan, how about you? What is your approach in terms of liquid biopsy versus tissue biopsy for genomic sequencing?
So we have the luxury here that cost is really an issue for me. So I totally agree that tissue is always a good standard, and it happens at times that it's not only the genomic sequencing, even ER or HER2, and they may change, and when the cancer is progressing. I had quite some patients, they either gained HER2 or they lost HER2 in the site that the disease progressed. So I always want to advocate for a new biopsy when the cancer is progressing, especially when it's a bad site, right? Especially when it's in the organs, in the liver, and in pleural effusions, etc. So, and I totally heard you, especially for bone disease, that bone biopsy we can do, and in center like us, we are really good at bone biopsy, but the success rate, even regardless how hard we try, it's 60 to 70% at most. So for that regard, if a patient has a really deep lung lesions, and if I had to be super invasive, intubate the patient for a biopsy, I would not pursue that. I think at that point, liquid biopsy would be very reasonable. And I use all of those tests, Foundation 1, Tempus, and Guardant. I use all of them. And circle back to the cost, and actually we do have a in-house NGS panel that we only test limited genes. It's only 8 genes, but included ESR1 and PIK3CA. So the nice part of that, and our pathologists, they just do that for us. And the nice part of that is you don't have to deal with the outside company, and you don't have to wait, and in-house pathology is easy to talk to, turnaround is faster. So I think that's a very nice option too.
Sure. Yeah. And so for those of you on the call who may not know about some of these things, so the Foundation One and Tempus are 2 labs. Basically, these are commercial companies that do tumor sequencing, and they are usually mostly based on tissue tumor sequencing in the United States. So that's what they are. The Guardant, on the other hand, is a liquid biopsy company. So by liquid biopsy, as I explained earlier, it's basically drawing the blood rather than going for the tissue, drawing the blood and then looking for tumor DNA in the blood. So obviously, as Dr. Yan and Dr. Sirohi explained, there are limitations and benefits to both. So moving forward with our case, so we found that she had ESR1 mutation and PIK3 kinase, the PIK3CA mutation. So I think these are both very important mutations. If you look at, so this is a study that looked at 155 breast cancer patients who were metastatic, and they looked at the prevalence of ESR1 and PIK3CA mutations. So if you look at the ER positive, HER2 negative patients, which is the most common subtype, they found that 30% of patients had ESR1 mutation and 30% had PIK3CA mutation as well. But if you look at HER2 positives or triple negatives, the rate of ESR1 and PIK3CA mutations are obviously much lower. So these mutations seem to be very much important and relevant in ER positive, HER2 negative breast cancer. And this is kind of similar to our case as well. So you had ER positive, HER2 negative breast cancer where we found this. But what I found also interesting is how these mutations develop and how these mutations change over the course of time. So if you look at the alterations that develop over a course of time. So this is looking at the Paloma-3 trial, which looked at fulvestrant with palbociclib. And what they found was, if you look at the ESR1 mutations over here, they found that prior to treatment, almost 30–40% patients had ESR1 mutations, and that was maintained throughout the treatment as well. Roughly 20% or so we had mutations that were lost. So ESR1 mutation, they had the ESR1 mutations prior to treatment, but were lost during the treatment. And then the majority, which is almost, if you do the percent maths, was 40–50%, had a new mutation developed during the course of their treatment. So a lot of these mutations are acquired during the course of treatment as well. If you look at PIK3, on the other hand, same thing. So the blue line represents how many had PIK3 prior to starting treatment, and then the purple line represents how many developed new mutations at the end of the treatment, how many had PIK3 mutations. And it was obviously statistically significant. So it seems like a lot of patients may not have the mutation right at the outset, but during the course of their treatment, they may develop ESR1 or PIK3 mutations. What was also interesting to me was noting at what happens during the course of treatment. So if you look at those who did not acquire mutation, they had, in fact, a median PFS of 5.5 months, meaning patients who rapidly progressed through a particular treatment did not really acquire ESR1 or PIK3 mutations, whereas patients who, in fact, responded very well to treatment and had, in this case, median PFS of 14 months, those were the ones who acquired ESR1 or PIK3 CA mutations. Now, this, in some ways, is almost counterintuitive because my thought initially was that patients who develop these acquired mutations would probably progress rapidly. But looking at this, it seems like these mutations, in fact, develop very late in the treatment and maybe a resistance mechanism, after several months of treatment. So again, I would like to bring in Dr. Yan over here and to talk a little bit about, so if these mutations are acquired at different phases of treatments, I mean, does that mean that we should be doing biopsy at every progression? Or how do we interpret these results?
Yeah, to be honest, do I biopsy each of my patient when I change management? No, it's not realistic. But for instance, when I have a patient that all the other I just saw a patient not yesterday, Friday. So all of her other cancer side were really quiet, and all of a sudden she has multiple liver mets pop up. And so she went through quite a few lines of treatment, and we were debating if she was HER2 negative or positive. But regardless, she had lung nodules, and all the other side were really quiet and no evidence of disease. But those liver lesions just pop up all of a sudden and did not make any sense, and it's multiple. So for that, I would definitely want a liver biopsy because some of her cancer were HER2 positive, some were HER2 negative, and I didn't even know what to expect. So for that, I would advocate for a liver biopsy, and the patient is totally on board for that. But when a patient, especially for the ER positive, HER2 negative, that patient has a very long survival. And I had quite some patient metastatic ER positive. The last tissue I had was 12 years ago. And the disease tend to be benign, and I can just get around with liquid biopsy, and sometimes I just get around with empiric treatment. I always want to advocate, but of course it's a case by case discussion, right? So
Sure.
yeah, but this makes totally sense that with more information, with more genomic tests, and we should have more information to tailor the treatment for the patient.
Sure. Dr. Sirohi, what is your approach in terms of, and does this data make sense to you that acquired mutations happen more later, and like patients who do have mutations? In fact, in this case as well, this patient was responding to treatment for 2 years, and now she has PIK3 and ESR1 mutations.
I think the mutations are acquired through longer exposure to endocrine treatment. And patients who have done quite badly on patients with no acquired mutations are the ones who probably have primary resistance to CDK4/6 inhibitors or fulvestrant. Either they have something like loss of RB gene because the retinoblastoma gene, which is there in 5% of patients, and quite a few other reasons. So longer exposure to endocrine treatment does lead to acquired mutation. And I agree with Dr. Yan that, ideally we would want to do a liquid biopsy at every progression to see if to follow up the patient if there was no cost issues involved, to see if the levels have gone down or the patient has acquired a new mutation, which can be druggable or targetable with the drug that's available.
Perfect. Thank you. That makes sense. We have a question in the chat saying, in this scenario, would you also have a hereditary panel that sees young and we may need further treatment options? And I think Dr. Yan answered that. I think for all metastatic patients, we are always looking for treatment options. And I think doing genetic testing germline genetic testing for BRCA1/2 would make perfect sense. Would you agree, Dr. Sirohi?
Yeah, I would do the whole germline panel, which includes PALB2, ATM, check, and the other mutations as well. The whole hereditary breast and ovarian cancer panel in her. And also, I would try and, if finances were an issue, which, you know, in our part of the world they are, I would try and do a biopsy for just HER2 immunohistochemistry, because we know that in about 20 to 30% patients, that would change management.
So what is one of the things I think, again, is being brought up is the cost of these things. So how much does Guardant 360 or hereditary panels cost in Nepal or India, Dr. Sirohi?
So so foundation costs about 3.6 lakhs, so 360,000 rupees, and Guardant costs exactly the same. And there are a lot of Indians. So, you know, a lot of times when I do these meetings, I'm asked which company to go with, because there are so many companies which are doing these tests. And in India, you have a lot of homegrown companies as well, like Strand, Datar, MedGenome, quite a few others as well, which are doing it at a fraction of the cost. But it's quite a few of the data is not validated. And so like it is with Foundation and Guardant, so that is the downside, but it is very expensive. So I do the tests with some of the Indian vendors if cost is an issue.
Sure, certainly. That is always something that I think we all have to keep in mind, because it's you know, when we are saying that at every progression there could be new resistance developing, but if the cost is that high, I think we have to be judicious about when to order these tests. So the other discussion moving forward, I think if you look at ESR1 mutations and looking at the clinical significance of that, you know, these are so I think one of the things that I would want to highlight in this slide is that these are studies, these are from different studies, so you can't really compare the columns, but I think what would be important is to look at just within a particular drug, how ESR1 mutations impact the PFS and OS. So if you look at fulvestrant, this is looking at two clinical trials, SOPHIA and IFACT. What they found was those with ESR1 mutations had a PFS of 3.9 months, ESR negative had 4.1 months, very comparable. Survival as well was very comparable, 80% and 81% 1 year survival. Exemestane, on the other hand, was this was very remarkable. If you look at it, ESR1 mutation positives had 2.4 months PFS, whereas ESR negative had 4.8 months. Overall survival as well was very different, 62% for ESR1 mutation carriers and negative 79%. If you look at exemestane and everolimus as well, there was difference in overall survival between those with ESR1 mutation and those who did not carry ESR1 mutation. Bottom line is, it appears that for fulvestrant with ESR1 mutation, it does not really matter. It does not really seem to be different, the PFS or OS, between those who carry ESR1 mutation or those who do not. Whereas for exemestane and everolimus, it does seem like that the PFS and OS seem to be lower in those who have ESR1 mutation. Now, based on this data, I guess the question that, because if you just look at the ESR1 mutations alone and we don't think of the PIK3 mutation, would that sway you in any ways about choosing fulvestrant over exemestane and everolimus if somebody has ESR1 mutations? Dr. Sirohi, what are your thoughts on that?
So I think you've answered the question. In the SOPHIA and the AFFECT trial, which tried to look at fulvestrant versus an aromatase inhibitor, patients who had ESR1 mutation did better with fulvestrant. So and that was the dose used in these studies was 250 milligram, which we no longer use. We use 500 milligrams of fulvestrant. And we know that the ESR1 mutation actually can cause relative resistance to fulvestrant and tamoxifen as well. And in the CDK4/6 trials, we know that it is prognostic but not predictive, the ESR1 mutation. So patients who carry an ESR1 mutation have a poorer prognosis. But looking at the SOPHIA and the effect as you have shown, I think I would go for fulvestrant 500 milligrams if the patient had an ESR1 mutation.
Gotcha. Dr. Yan, any thoughts on that?
Oh yeah, I check ESR1 mutation a lot, almost routinely. After patient actually, and actually for me, I'm running a research project that for metastatic ER positive HER2 negative, we tend to drag our feet to have the genomic test. But now actually I'm running a research project that I'm advocating for genomic test upfront. Reason of all those ESR1 mutations, they can be acquired later, but they could be de novo to start too. So, I totally agree that, ESR1 should be checked when the patient progress on the first line treatment. Yeah, I almost always check that too.
Okay, so moving forward, so that was the ESR1 part of this. Now looking at the PIK3 kinase, the PIK3CA mutation. So this is where I think the field has moved forward, and it's very exciting. We had the SOLAR-1 trial published last year, and what this study did was they had two different cohorts. They had a PIK3CA mutant cohort, and they had a PIK3CA non-mutant cohort. And in each of these cohorts, what they did was used a combination of alpelisib with fulvestrant and compared it to placebo with fulvestrant. And what they found was, and so if you look at the enrollment criteria, these were all postmenopausal women with hormone receptor positive, HER2 negative, advanced breast cancer with recurrence or progression on prior AI. And so what they found was very interesting, and this is just in the PIK3CA mutated cohort. They found that there was significant difference in the progression-free survival. So median PFS for alpelisib with fulvestrant was 11 months, whereas placebo with fulvestrant was 5.7 months. Now, in the non-PIK3CA mutated, so in the PIK3CA wild-type cohort, they did not find a difference in progression-free survival. The overall survival data has not been reported, and so we don't know if this makes any impact on overall survival or not. So this sort of opens up a new treatment option, in this case at least, with fulvestrant and alpelisib. So I guess that brings us to sort of towards the end of this case. With knowing the ESR1, knowing the PIK3CA kinase, Dr. Sirohi, what would be your choice of treatment in this case? What would you favor proceeding with treatment after progression on palbociclib and AI?
So I think that the data is quite impressive. I would go for fulvestrant and alpelisib if it was available, and again, if costs were not an issue.
How much, again, I think we keep on going back to the question of cost, and how much is the cost on alpelisib?
So I think in my clinical setting, most of my patients, even fulvestrant is quite expensive. So I would tend to go towards maybe not exemestane and everolimus, but possibly tamoxifen and everolimus, because we know that ESR1 mutation is predictive of resistance to AI. So, and there's relative resistance to fulvestrant and tamoxifen. So most of the times I would end up, because we have a generic everolimus. So I would go for tamoxifen and everolimus. And because fulvestrant is also quite expensive, it's about 35 to 40,000 per injection, and patients need to get 2 doses intramuscular every month, which is for slim ladies, it's quite painful, and it's seriously affects their quality of life. Alpelisib is again quite expensive. The cost is in lakhs, and if you add it to fulvestrant, I think all of these trials are done in high-income group countries, and they're combining 2 drugs, 3 drugs, 4 drugs, immunotherapy, which I think where 70% of the cancer patients live, that's low and middle-income group countries, we don't have access to because patients can't afford it. So, or the other option in real-world setting would be capecitabine. So, which is again very easily affordable and easily available.
Yeah, definitely. Dr. Yan, how about since you practice in the US and some of these limitations may not be applicable, what would your choice be?
because this is a young woman and with bone-only disease, and to be honest, even cost is not an issue with bone-only disease. You would anticipate this woman may potentially do well, actually, even on hormone therapy only, because she had the ESR1 mutation. If the patient is totally against any more treatments, just giving fulvestrant alone wouldn't be a very reasonable option, just to kind of watch her. And also, it's not unreasonable at all because it's bone only, and it's kind of benign process. So I would be okay with fulvestrant only. But if the patient is really, she wants to be aggressive, she does have the PIK3CA mutation, and we all know that with the mutation, the patient tend to progress quickly. So I have a handful of patients that actually is on fulvestrant and alpelisib. It's actually a very appealing approach, and so it's actually very well tolerated. And I have the luxury. I have two nurses, and they have 30 years of experience in oncology, and they are expert in doing the fulvestrant injection. So I don't even want to send my patient to any other nurses. So my nurse is here doing the injection for my patients, and most of the time I barely have any side effects from the injection. So I know I have the luxury that I don't have to worry too much about the cost, and I have access to the medications. But if you look at this young woman, she's young, and she has the ESR1 mutation, and she has a PIK3CA mutation. So I would advocate that nowadays we should be smart and we should target the mutation for patients.
Sounds reasonable. We have a question in the chat saying that would you continue denosumab or change the bone modifying agent as well?
Oh no, I would continue the denosumab, and there is no evidence to tell me that denosumab is better or inferior to Zometa. However, we have to be aware that the commercial name Xgeva is FDA approved every 4 weeks, and Zometa, however, we have data that you can space out to every 12 weeks. So often the time I have patients that we space out Xgeva to every 12 weeks because of the data, and it's just too frequent. And when it's bone-only disease, and I often just go back to Xgeva every 4 weeks, and sometimes they just do the trick. But I'm not sure if that applies to this patient because she has a mutation, but often the time just kind of go back to every 4 weeks can do the trick.
Sounds good. Sounds good. So kind of just the summary of this case, and as you see, so that these mutations can happen during the course of treatment, and we talked a little bit about the prohibitiveness of the cost and the challenge of getting these treatments in countries like Nepal or India. And in that context, I think Dr. Sirohi had brought up a good point about how expensive molecular labs are. And I think one of the things that BTFCC is trying to do is establish a molecular lab in Nepal, which will be, my understanding, is one of the first NGS lab in Nepal to be able to run some of these PIK3, ESR1, these kind of mutation testing in Nepal. So we're very excited about that. I mean, it's a process. There are a lot of challenges to getting it done, but hopefully we should be there in the next few years. So,
could I take this question? One more question, Sid. Just
sure.
So it says that will the Guardant cover all the genes, and hereditary panel costs around 15,000, but Guardant panel. So I just want to make a point that Guardant panel is testing for the somatic mutations. So if you do find something, you must do germline testing separately as well.
Yes.
So for genetic counseling and for family, yeah.
Yes, definitely. I think I think the Guardant 360 is mostly just we are trying to evaluate for somatic mutations. I would not order it for germline aspect of things, and the germline panels should be very different. So moving on to case 2, since we're talking about some germline aspect of things.
Can I interrupt for a second, please?
Yes, definitely, Dr. Shah.
So I would like to get comment from Dr. Ghassan Abu Alfa. Based on his experience in global oncology outside Nepal and India, how is the situation in terms of access to genetic testing as well as affordability of these newer molecules?
Well, thank you so much for asking me, and I'm glad you asked me because I had a lot of comments, but I have the time. By all means, number one, as a disclosure, I don't do breast cancer, but interestingly, we got a little bit interest in breast cancer for the understandable reason that already were brought up, which is that some of the alterations that occur in breast cancer occur also in gallbladder cancer, especially HER2. With this said, number one, regard to the next generation sequencing, no doubt there's a lot of platforms that are available. They're all good, but however, some of them are not necessarily as extensive as others. And even though they might address the critical key players in the things like CD1K that just we brought up and others, some of them are broader. It might look a little bit promotional, but to be fair, Memorial has one of the largest, if not the largest, platform of the impact, which spells IMPACT in capital letter. And this is like close to 500 genes. The nice thing about the impact at Memorial is that, which is going to be brought up now in case number 2, is the genetic component. Because we have actually an impact in ability to also analyze for the genetic alterations and not only somatic. And the spectrum of the genetic alterations that you can really evaluate is close to 100, which is a very broad, if not the broadest, again, the genetic alterations that we can understand from that perspective. Now, with this said, a comment in regard to the tumor liquid biopsy and Guardant. Yes, I can see the value, especially if the no tissue is available, etc. But we have to be very careful about 3 components. Number one, as we all know, this is a sample of what's floating through the blood. And in other words, if the blood is taken at a moment where not a single sample was in that blood specimen that was acquired, this might imply that after all it was negative while it's not. So it has really a very high false negative. And at the same time, we very much worry that alterations that might occur are not necessarily always the ones that are shed by the tumor and be kind of present in the tumor, but rather something that could be not necessarily of significance per se. So I would say, yes, short of nothing is better than nothing, but at the same time, always it's important supported with the real biopsy because this is where the value is. With all this said, I will wait to hear the second case, but one of the fascinating things, as we all know, that BRCA mutations, that at least the perception that we had originally, which is to be fair, is still very valid, is very common among specific ethnicities. But now we have a clearer understanding about that it's much broader than this and can apply to different ethnicities and could be all over the world. There is data that came out of India. There's data that came out of Pakistan. Same thing, there is data that came out of the US, out of Israel, out of Saudi Arabia, and many other places in the world where the BRCA mutation have shown. The fascinating thing is that none of those have ever been compared. And the reason it's really important to compare is to really see if the application of therapy will be different or the same based on the patient come from. So funny enough that you brought this up, this is still in the kind of semi-private, but we already have a audacious project that we applied for looking into the genetic alteration among different ethnicities and etiologies to really try to better understand specifically the BRCA or could be other mutations as well. And I know we're going to talk about the POB2, but I'll hold off. We'll talk a little bit more about that later.
Sure. Thank you, Russell. Now, I would also invite Dr. Joseph Rojales to talk briefly about how things. I know you have ties with the Philippines. Can you do you know how the access to these molecules, access to the genetic tests, and potential cost in the Philippines? And Dr. Joe Rojales practices in Seattle. Joe?
Yeah, sorry. This is Joe Rosales, a medical oncologist at Virginia Mason in Seattle. I don't practice or have too many medical colleagues that I communicate with in the Philippines. I have people that I discuss this with there commonly. Unfortunately, in the Philippines, the situation probably similar to other parts of the world. There's not a lot in terms of medical insurance. And so, unlike here in the U.S., where people have very easy access to many, especially the older endocrine therapies with a relatively reasonable copay, the Philippines, whether or not you get the medication is entirely based on your ability to pay. And so the older drugs, for instance, tamoxifen, I think anastrozole, which is now generic, are a lot easier to get than the newer ones. Exemestane, I think, is still difficult in the Philippines. Certainly, palbociclib and fulvestrant, those are unfortunately prohibitively expensive in the Philippines. And so a lot of times people who have the means will go elsewhere to be able to get medication. But for the majority of people in the Philippines, similar to other parts of the world, they are limited in terms of what they can afford and what's available locally.
Thank you, Joe. So one of the goals we have is we talk about the cutting edge treatments, the diagnostics and treatment options right here, and what we do in the United States, what we do in leading institutions like Memorial Sloan Kettering, Mayo Clinic, and other places. We also want to see how we can apply the same treatments in low and middle income countries, because the access to treatment, access to genetic testing is improving, and it is going to improve further. And as Dr. Siddhartha Yadav pointed out, we are working on creating our own next generation sequencing lab right there in Janakpur in Nepal. So while some of these things you may think would not be applicable in Nepal, that is not true. In fact, even now we do a bunch of these tests in Nepal at BDFCC in Janakpur, and we plan to expand our ability to do all these things. Thank you, Sid.
Thank you, Dr. Shah. So let's move on to case number 2. So this one again is a young female, 46-year-old. She was noted to have a 2.6 centimeter mass in the right breast with palpable lymph nodes. And it was biopsied. It came back as grade 3 triple negative invasive ductal carcinoma. And she underwent germline genetic testing. So we have this, we typically do germline genetic testing prior to surgeries just because we want to see if that would impact the choice of surgery as well, whether bilateral mastectomy or lumpectomy. In this case, she was found to have a pathogenic variant in PALB2, and this was a deletion of exon 12 to 13. So with this PALB2 mutation, and also her preference was to undergo bilateral mastectomy. And in the surgical specimen, it was noted that this was invasive ductal carcinoma measuring 7 centimeter. 7 out of 27 lymph nodes were positive, and so she was fine. The final stage was stage 3. She received adjuvant chemotherapy with AC 4 cycles followed by weekly paclitaxels of 12 doses of weekly paclitaxel. For 2 years after the treatment, she was disease-free and there was no evidence of disease recurrence. However, in 2019, she developed abdominal pain, which led to PET-CT scan, and that was suggestive of bone and liver metastatic disease. Liver biopsy was performed, which demonstrated recurrent triple-negative breast cancer. It was PD-L1 negative. So Foundation 1 was ordered as well, again, tumor, and this was ordered from the tissue, and that noted an amplification of FGFR2 10q26. So there are 2 molecular alterations in this case that are worth considering, right? So first one is obviously there is germline PALB2 deletion, and then second one is the somatic mutation in somatic FGFR2 amplification in the tumor. So let's talk about the germline PALB2 deletion first and its implications on clinical care. But before we even go there, I think one of the questions that were brought up earlier as well was, I mean, who needs germline genetic testing? And in metastatic cancer, I think Dr. Yan had mentioned is that we would probably do testing on everybody to figure out whether there would be any role for PARP inhibitors, and that's usually PARP inhibitors are approved for HER2-negative metastatic breast cancer. Now, in non-metastatic cases, I think this is where it starts becoming tricky is if you look at the NCCN criteria, at least in the US, they say do not test everybody with breast cancer, test based on AZ diagnosis, histopathology, personal history of cancer, or family history of cancer. Whereas if you look at American Society of Breast Surgeons, they suggest that you should test everybody who has breast cancer diagnosis. And so irrespective of AZA diagnosis, irrespective of personal or family history, just test everybody for germline mutations. And this is where it really becomes, so the field is really divided into, there are people who support NCCN criteria, there are people who support American Society of Breast Surgeons criteria. So we had, our group at Mayo Clinic had looked at comparing American Society of Breast Surgeons and NCCN criteria, and we had this study published earlier this year in JCO. What we found is if you look at, so if you look at 12 breast cancer genes, which are the most common and the genes that have been established as predisposition genes for breast cancer, if you look at if you just follow the NCCN criteria on the left side, you'll find that your sensitivity for the 12 breast cancer genes is 70%, meaning if you go by NCCN criteria, you're going to miss 30% of germline mutation carriers. If you test everybody, you would get to sensitivity of 100%, which is the American Society of Breast Surgeons. But obviously, you're testing a lot more people, and that's where the question of cost comes into play as well. Even in the US, not all insurance carriers pay for germline genetic testing. What our study found was if you test those meeting NCCN criteria or those who were diagnosed with breast cancer under the age of 65, you can pretty much reach a sensitivity of 90% plus for 12 breast cancer genes. For BRCA1 and 2, you reach a sensitivity of 98%. And with this approach, you don't have to test everybody. In fact, you avoid testing in roughly 30% of breast cancer cases. So that's kind of our approach at Mayo Clinic, at least the group that I work with, we tend to do testing on everybody who meets NCCN criteria or has been diagnosed with breast cancer under the age of 65. Over the age of 65, we sort of take it on a case-by-case basis. So I would like to bring this up because this is a topic that often comes up. So starting with Dr. Sirohi, what is your approach? I know cost is obviously a big limitation in India again. So what is your approach in deciding who should undergo germline genetic testing?
So I think broadly we follow the NCCN criteria. They have increased the age from 40 to 45 years now.
Yep.
So the only difference is that I would test all triple negative breast cancer patients because we have a treatment modality available for patients who have the germline mutation. And again, like you highlighted very well, patients above 65, we don't know what the clinical utility is. So I wouldn't consider doing that. So I mean, having worked in the NHS for 2 decades, I think broadly these are the criteria we follow. The age is less than 40 years in the NHS. Here it is about 45 years.
Yeah.
I would do it in less than 45. And
Sure.
cost is not that much of an issue for BRCA. What we do is we do it with NGS, so it's about 10 to 15,000 rupees. And with NGS, if it comes negative, then to look for the large deletions, you'll send it for MLPA. Then it adds another few thousand. So the germline testing with the Indian companies is not so much, but if we send it to Myriad, it's about 4 lakhs.
Oh, wow. Yeah. Dr. Yan, what is your approach in terms of germline genetic testing in breast cancer cases?
So actually, I have the luxury that I have 4 genetic counselors sitting on the same floor with me.
That is amazing.
Yeah, same floor. I have psychiatrist and genetic counselor, everyone on the same floor with me. I have a tremendous amount of support. So and actually, I see everyone before surgery. So even it's triple negative, even it's a 78 ER positive, I try really hard to see all the patients before they go for surgery. And I totally agree that, like I said, if it's a metastatic, I send them to genetic counselor right away. They need to be tested. And if it's a young patient, when I say young, it's less than 65. And, I try really hard to convince them because some patient actually even is covered by insurance. They don't want to have that because of the worry of life insurance and of the worry if they get discriminated, even we have a law against it. So, but if it's a young patient, younger than 65, I almost want to advocate to make sure you are tested. And for those women older, they are 70s, they are 80s, they don't have a good family history. I mentioned to them, telling them that, if you really want to know, if you want to have this information for your children, it's available. And I got surprised. I got an 82-year-old, she did not have much family history. And she was like, oh, no, I have 7 children. I want to test this for my child. So she went for test, and right before she was ready for radiation, she actually had a p53 mutation. We got surprised, even in single cases, but we got surprised. So, I totally agree that, for metastatic, for younger patient, it's available, and I barely have any insurance coverage. And for older patient, no family history. But for me, I have very strong genetic counseling support, and it's almost always covered. And I don't have much issues at all with insurance coverage.
Sure. So let's talk about the DNA repair pathway and where PALB2 falls into. I mean, obviously, we are all aware of BRCA1 and 2, but if you think of the DNA repair pathway, there are several other genes over the last 10 years which have sort of gotten into prominence, and now they are included part of a germline genetic testing panel. So, typically when you have a ionizing radiation or for collapse and leads to DNA damage, the usual activation pathway starts with ATM, then BRCA1, and PALB2 is somewhere in between BRCA1 and BRCA2. And it is a very important gene. I mean, if you, the full form of PALB2 is partner and localizer of BRCA2. So it's kind of considered as a cousin of BRCA2 in many ways. And then these are all genes that are involved in your homologous recombination. What is important is over the last few years, we have now figured out we have now data to say does the risk of breast cancer look like with PALB2 carriers. So if you look at of all breast cancer cases who undergo germline genetic testing, which meaning meeting NCCN criteria, roughly 0.8 to 1% will carry a germline mutation in PALB2. If you look at the breast cancer risk in PALB2 mutation carriers, so lifetime risk by age 80, what is the chance of developing breast cancer? So if you look at general population without a germline mutation, that's risk somewhere around 12%. Whereas for PALB2 mutation carriers, these goes somewhere between 50 to 60%. In comparison, if you look at BRCA1 and BRCA2 and look at what is the lifetime risk of developing breast cancer, that's somewhere around 70%. So PALB2 is considered a very high-risk gene now. Any gene with a lifetime risk more than 50% is considered as a high-risk breast cancer gene. So the challenge, though, is when you think of bilateral mastectomy in PALB2 carriers, we do not know the contralateral breast cancer risk. And in BRCA1/2 carriers, we know that the risk of contralateral breast cancer is 20 to 40%, and it's higher in BRCA1 with 41%. The NCCN guidelines used to say PALB2 insufficient evidence to decide whether bilateral mastectomy is indicated or not. In the recent update, though, however, they suggest that discuss options of risk-reducing mastectomy with PALB2 carriers as well. And I think that's just based on increasingly we're recognizing that this is a high-risk gene and that the risks are probably as high as BRCA1 and 2 as well. So in this case, so stage 3 breast cancer, CR bilateral mastectomy, and now recurrence. So if you just think without looking at the molecular alteration, I guess our standard approach would be in triple negative breast cancer metastatic would be chemotherapy, especially because it's PD-L1 negative. But the question then comes up is, with the germline deletion in PALB2, would PARP inhibitors be indicated? And really, there isn't much data to go by. I mean, the data that we have is really for BRCA1/2 carriers. And this is looking at the Olympiad study, which looked at olaparib compared to placebo in HER2-negative BRCA1/2 carriers, and olaparib improved the progression-free survival. Same data with a different PARP inhibitor called as talazoparib. Again, this is the IMBRCA trial where they also noted that progression-free survival improved with talazoparib in BRCA1/2 mutation carriers. The only data that recently came up, which is very exciting for PALB2 carriers, is from this year at ASCO. presentation. This was Dr. Nadine Tang talking about olaparib monotherapy in metastatic breast cancer with some of these other genes beyond BRCA1 and 2. And so they looked at stage 4 breast cancer. They had less than 2 lines of prior treatments, and then who were not refractory on platinum-based disease. They had different other germline mutations in ATM, BARD1, and PALB2 was part of that. They also allowed somatic BRCA1 and 2. And so they gave olaparib 300 milligram BID for 3 weeks, and then they looked at tumor assessment, and then they looked at 6 weeks and 24 weeks, and then every 12 weeks, and looking at whether this was a phase 2 trial, single arm, so they were not really looking at PFS. They were mostly looking at response rates and those kind of things. The interesting thing about this, if you look at the greens are the ones, the patients who responded. And if you look at all the green ones, so PALB2, 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 pretty much all of the green ones are the PALB2 ones. And then if you look at the other ones where there was best chains of progression, all those things are the other germline. So PALB2, in fact, in this study seemed like they really had good response. So if you look at just PALB2, there were only 11 patients with PALB2 germline mutations. 9 had partial response, 2 had stable disease. So almost all of them had at least some degree of response. None of them had progressive disease. Also, if you look at duration on therapy, again, these all green ones are PALB2 carriers. They are the ones that they have been. So the longest one has been on the therapy for 92 months now. So that's quite impressive. So that sort of brings up the question then, obviously in the US, there is no FDA approval for PARP inhibitors for PALB2 mutation carriers. But would you consider, Dr. Sirohi or Dr. Yan, would you consider PARP inhibitors in this case?
Only in the clinical trial setting, because this is Part B2. This is not BRCA1/2. So I struggle with insurance. Even I feel I'm luckier compared to colleagues from other countries, but I struggle with insurance every day. And it's not FDA approved. And I would argue that potentially it's a very appealing option, but insurance would not cover for that. So for those kind of actually for metastatic triple negative, I do every single effort to look for clinical trial, and I think there is a clinical trial going on right now, but it's only in the clinical trial setting. I don't think I can give PARP inhibitor outside clinical trial setting right now.
Sure. So the other thing that comes up is obviously the platinum-based chemotherapy as well. Again, data on BRCA1 and 2 suggests that this is from the TNT trial, suggests that they respond well to platinum-based chemotherapy. So the orange line over here is BRCA1/2 carrier with platinum-based chemotherapy, and then the bottom line is BRCA1/2 wild type with platinum-based chemotherapy. So there is some data to suggest that they may respond better to platinum-based chemotherapy as well. So that's something, again, could we extrapolate these to the PALB2 carriers? I mean, we don't have data to suggest that. And finally, I think, in this case, I think the Fgfr2 amplification, I think briefly touching upon that, I mean, these are common amplifications, say FGFR1, FGFR2. And if you look at triple negative, the FGFR amplifications, you'll see that in 4% of cases overall. And there are several, again, drugs that are available right now for FGFR, which are FGFR inhibitors. Again, as Dr. Yan was talking about, these are mostly in clinical trial for breast cancer right now, not approved for therapy. So, to summarize this case, in fact, in this case, what we did was in 2019, she was started with this metastatic disease, started on capecitabine, responded for 6 months, and then switched to carboplatin, also had partial response in that. We were able to get PARP inhibitor on her for her off-label, and understanding that this is off-label indication. We did not have a PARP inhibitor clinical trial over here. And she continues to respond.
Can I ask you which PARP inhibitor did you get? How did you get it?
So this was olaparib, and so this was just we wrote for it, and then we were able to. It's usually depends on their insurance. Some insurance are very sticky about this. Some insurance are like, okay, fine, I'll give you try PARP inhibitor. There's no.
It's very insurance dependent.
Yeah, exactly. And so on this, so restarted. If she progresses, the plan is to either restart carboplatin. We also have a FGFR clinical trial with TAS 102 right now, which recently opened. So the plan would be to either switch her to FGFR study. So I think that's kind of what this case would end. Any final thoughts, Dr. Yan or Dr. Sirohi, on this case?
So I would like to, in pancreas cancer, we have started using olaparib in PALB2 mutation as well, and looking at the data from ASCO this year. So I would, like you have done, I would not hesitate in when I've run out of options in recommending a PARP inhibitor. So I would like to ask Dr. Ghassan whether so the data for pancreas, whether we can do the same in breast as well, and maybe use olaparib earlier on because she continues to respond. So this might have been a good option and an oral drug to begin with.
Yeah, thanks so much, Bhawna. So two questions. Number one, or rather two points to answer. Number one, in regard to the genetic testing, in general, I like very much what was brought up about the age of 65. Pretty much in general, yes, we follow the same, like up to age 60, 65, we'll do it. And of course, understand if patients are eager and keen, especially if there is any suggestion that could be related to genetics, by all means. But definitely young people should get genetic testing right from the start. Point number two, in regard to the use of the PARP inhibitors, in regard to quote unquote other malignancies, as was suggested either by other GYN malignancies or even in GI malignancies, by all means, I can see the value of using PARP inhibitors in regard to PALB1, and I think I do agree on the perspective. Yes, we should probably consider that. And number two is, of course, we go through the same struggle in regard to insurance companies and approval rates. But funny enough, the question that you just asked, Bhawna, is exactly what happened literally just last Tuesday in clinic. Patient with a cholangiocarcinoma with BRCA genetic mutation. And the patient did extremely well on chemotherapy and now, quote unquote, maintenance therapy. And after going back and forth for a while, because maybe it was triggered for us a very subtle, barely few millimeter lesion in the lung, which could be nothing, but we felt like, you know what, enough to justify putting on maintenance olaparib. And that's exactly what we did. So what's going to happen, I'll keep you posted.
Thank you.
Thank you, Dr. So to summarize, I think molecular testing can inform and change our management decisions. We talked about prognosis with ESR1. We talked about treatment decisions with PIK3, selection of chemotherapy. Would you choose a carboplatin? We talked about clinical trials options, FGFR. We also talked about off-label treatment decisions such as PARP inhibitor and PALB2, and then obviously surgical decision making. And I think there were a couple of good points from Dr. Sirohi. I think in the chat is VUS. I would not make any treatment decisions based on VUS because we truly do not know. And 80–90% of those eventually do get classified as benign. So that kind of ends our molecular tumor board for today. Unless anybody has any final thoughts, Dr. Shah, Dr. Sirohi, Dr. Yan, any final thoughts for today?
So I think my just for triple negative, I would try and find something. So my thing is I would do, of course, ER/PR, HER2, but I would also do androgen receptor,
Sure.
MSI, and you can do NTRK by IHC for screening. So I would do this before moving on to the genomics. So if we find something, then I would try and target that with that, because we had a patient with MSI high who did extremely well on pembrolizumab. Again, it's very anecdotal.
Sure.
Okay, Siddhartha, outstanding job, and outstanding job, Bhavna and Dr. Yan. And Ghassan, thank you for all your inputs. And I would like to thank all the attendees for being here. So I think, These meetings that we are going to do once a month, these are going to delve into the newer technologies, newer treatment options, what can be done in the United States, considering we have constraints because of insurance policies of patients, and what can be done outside the United States, considering some other constraints we have. So it is truly kind of global meeting that helps us understand how to best take care of patients in view of most cutting edge evidence that we got here. So next meeting would be on CLL. And we will have Dr. David Obolofia from Virginia Mason. And I'm expecting Dr. John Pagel from Swedish, and he is world-renowned CLL expert. We are also expecting Dr. Venugopal from Rush. So we will have 3 outstanding speakers, and of course it will be moderated by Sid. So thank you all.
Thank you. Thank you so much. Bye-bye.
Yeah.
Bye.
And thank you,
Bye.
Dr. Sirohi and Dr. Yan, for joining us today.
Thank you so much, Sid. Thank you. It was brilliant. Thank you.
Thanks. Bye.
Thank you, everyone.